Good evening, ladies and gentlemen. On behalf of my colleague in the organizing committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, all GCC countries, and all countries across the globe to this webinar. This webinar is Pediatric Neurology. It is conducted in collaboration with NMC Specialty Hospital Dubai. I would like to thank the management of the NMC Specialty Hospital for their help and support. This webinar, as usual, is sponsored by Biotics, New Country Health, UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali, who is always helping us. Well, today we have eminent speaker and panelists. In a short while, I'll be introducing them. As usual, we are having a question. I would like to request all viewers to just write in the chat box who is this gentleman, why he is famous, and what is his contribution towards the pediatrics. In Dubai Pediatric Club also, from the beginning, with the help of enthusiastic members and excellent academic faculties, both from government hospitals and from private sectors, all we have tried also to be not only based in Dubai and UAE, but in GCC country and beyond, inshallah. Well, this has been shown in our previous webinar. We had 2,039 viewers from 60 countries. This shows how popular is Dubai Pediatric Club across the world. Thank you for your support. Well, my colleagues in the organizing committee of Dubai Pediatric Club, myself, Dr. Rajendra Joshi, the past president, Dr. Kalpana Sen-Gupta, secretary of the club, who is the moderator tonight, Dr. Diari Muhammad, chairman of the academic affairs. He is also moderator tonight, Dr. Amir Muhammad Tolema, Dr. Ayman Jundi, Dr. Rafia Ovara, Dr. Srinivas Bandari, Dr. Leila Bari, and Dr. Khalid Rashid. Well known to all of you. Well, as I said, tonight we are having an eminent speaker and panelist. Our speaker is Dr. Ubaid Shah, consultant pediatric neurologist and epileptologist at American Hospital Dubai. In a short while, I will tell more about him. The topic he is going to talk is with widgets and funny terms, an epileptologist perspective. Our panelist, well-known pediatric neurologist in Dubai, Dr. Vivek Mundeda, consultant pediatric neurologist at Medcare Hospital and Clinics Dubai. Our moderators, Dr. Kalpana Sen-Gupta, consultant pediatrician and head of Department of Pediatrics at NMC Specialty Hospital Dubai and secretary of the club, well known to all of you, and Dr. Diari Muhammad, consultant pediatric surgeon at Al Jalila Children's Hospital Dubai and chairman of the academic affairs. He is also very well known to you. I will give a brief introduction, and here I would like to inform our viewers that the 10th annual Dubai Pediatric Club conference will be held on 27th and 28th April 2024. Please remember that we will have 2 days physical. Another virtual conference we will have, the date will be announced, but these 2 days, 27, 28, is only physical. Well, our sponsor, Dr. Tawfiq Ali, the country business manager of the Biotics and New Country Health UAE. Well, after success in 9 conferences, webinars, symposia, he is planning for higher heights, maybe in Bombay. Well, I am going to talk briefly about the history of neurology and especially pediatric neurology in the world, in India and in the UAE. Well, I always start with the father of medicine, Hippocrates. Hippocrates was the first to describe seizure. Child neurology traces its origin to Hippocrates' description of seizure and other neurological condition in children. And one of his quotations I always love to say, first do no harm. Well, I start with Charcot. the father of neurology, the father of modern neurology. The neurology started in France from Salpêtrière Hospital in Paris. Charcot, his student, Babinski and Dejerin, they formed they are the pioneers in the field of pediatric neurology. More than 15 conditions are associated with the name of Charcot. I'm sure all of you know that. His student, Babinski. I would like to mention here, this is interesting to know how the Babinski became, famous. In those days in France, there were many ladies with hysteria. They were pretending to have organic neurologic features. But with a simple test, Babinski with this quill feather, with this, he demonstrated that those who are having hysteria, they have flexor plantar reflex. And those who have organic brain disease, they have extensor. That is why how this reflex became famous. Well, in Europe, Dr. Jackson is considered one of the pioneers of the neurology. Now remember this, Bernard Sack, the American pediatric neurologist, is considered as father of pediatric neurology. His name is with Tay-Sachs disease. Tay was the British ophthalmologist and Sack American pediatric neurologist. Both of them they described separately, and now it's known as Tay-Sachs disease. Well, in Europe, Frederick Batten is known as the father of pediatric neurology. Batten disease, you must be knowing. Well, question now, I would like to request Dr. Tawfiq to stop receiving question. The gentleman in our question is Henri Gachtot. In France, they pronounce it as Henri Gachtot. Henri Gachtot was awarded as ambassador for epilepsy by the International League Against Epilepsy and International Bureau for Epilepsy in 1968. He is from France and Marseille. He is considered as father of epileptology. Well, he died in 1995. In 1996, in his memory, Dr. Charlotte Drave, Dr. Sunny Phillips has talked a lot about Drave syndrome. His student, Dr. Drave, wrote, Henri Gachtot was one of the great pioneers who established epileptology as a respected discipline within neurology. Drave, Dr. Drave is a French pediatric psychiatrist and epileptologist, and her name is associated with Drave syndrome. Dr. Sunny has talked a lot about that. Well, Dr. Gachtot, actually, Dr. Lennox, this syndrome goes Lennox-Gachtot syndrome. Dr. Lennox is an American neurologist, and both together they describe separately, and now it's known as Lennox-Gachtot syndrome. Remember that. Well, the father of EEG, the first EEG started in children were done by Hans Berger, the German physiologist in 1932. Remember, we must remember them. And today, I'm sure they will talk about ophthalmoscope and ophthalmology. The ophthalmoscope was invented in 1951 by German physiologists Hermann von Helmholtz. Wait, briefly about neurology in India. The Neurology Society in India was established in 1951 by his pioneer Dr. Jacob Chandy in Madras. His colleagues, pioneers, Dr. Ramamurthy, Dr. Narasimha, and Dr. Baldev Singh, they were pioneers in this field, and they have been credited for pioneering the epileptic surgery. Today, Dr. Shah will talk about this thing. So remember them. And in 1991, Dr. Chopra, the professor and head of neurology at PGI Chandigarh, established the Indian Academy of Neurology. Please remember them. And Veena Kalra, Dr. Veena Kalra, all those who have worked in India and all India, they know Dr. Kalra. Dr. Veena Kalra, the ex-professor and head of pediatrics at All India Institute of Medical Sciences, New Delhi, initiated a 3-year course in pediatric neurology, that is DM neurology. And pediatric neurology section was established in 2017 at the Indian Academy of Neurology conference in Chennai. And Dr. Rajesh Udani, the son of great Dr. P.M. Udani, whose name is associated with TB meningitis, and he did a lot of work. He is the chairman, and Dr. Vinayan is a convener from Kerala, one from Bombay, one from Kerala. Well, pediatric neurology in Dubai, although before Dr. Gururaj, there were many pediatricians with a special interest in neurology. They were working especially in Latifa Hospital. But since 2009, when Dr. Gururaj joined, till 2022, he was there. He is one of the pioneers in the field of pediatric neurology in Dubai. He started his career actually in 1985 in Singapore, then went to Muscat, then came to Dubai. Very a true gentleman. Everybody knows him. Good academician, and he was there for a long time. He is one of the pioneers. Well, we have Emirate Pediatric Neurology Society, and some of its senior members are Dr. Muhammad Al-Hadi Al-Malik, is a consultant pediatric neurologist at Mediclinic, and Dr. Umar Ismail, consultant pediatric neurologist and chief at Sheikh Khalifa Medical City, Abu Dhabi. They are the senior pediatric neurologists in Abu Dhabi. Well, some of the well-known faces in the pediatric neurology in Dubai, Dr. Arif, Dr. Aman from Neuropedia, well-known to all of you, Dr. Pawan, head of Department of Pediatric Neurology at Al Jalila, our speaker, Dr. Shah, Dr. Sani Phillips, well-known to you at Mediclinic, Parkview, Dr. Hamza in Dubai Healthcare City, our moderator today, Dr. Vivek from Medcare. Here you see Dr. Samar, Dr. Nidesh, Dr. Muhammad and Dr. Abdullah. They are from Al Jalila Children's Hospital, and Dr. Ananda and Dr. Manoj, pediatric neurologists at NMC Specialty Hospital, NMC DIP and NMC Royal Sharjah, just to remember. Well, our speaker, Dr. Ubaid Shah, briefly, I have sent the profile to everybody, but just briefly I will introduce him. Dr. Ubaid Shah is a professor of pediatric neurology. He is an Australian board-certified pediatric neurologist and epileptologist. In addition to his pediatric neurology training at reputed hospitals across Australia, Dr. Ubaid completed George Gregan Fellowship in Pediatric Epilepsy. He is well known for his experience in complex epilepsy management. Dr. Shah is currently the director of the American Center for Epilepsy and has established a comprehensive epilepsy service at American Hospital Dubai. He is also regional director of DHA-sponsored pediatric residency program. Dr. Shah has particular clinical research interest in epilepsy surgery, invasive EEG monitoring, including robotic stereo EEG, intraoperative mapping, multimodal image processing, and neuromodulation. Very briefly, he has a big CV. Well, I end with the quotation by father of neurology. I love this. He said, disease is very old and nothing about it has changed. It is we who change. As we learn to recognize what was formerly imperceptible. Well, this is a lovely quotation I always quote. Emerson said, do not follow where the path may lead. Go instead where there is no path and leave a trail. We are trying to do in Dubai Pediatric Club that. My references, beautiful Dubai. I would like to request those who have not seen to come to this beautiful city. Dubai day and night. Sheikh Zayed Road and day and night, and Burj Al Arab, the first 7-star hotel. Thank you very much. I end here, and I would like to request Dr. Shah to start his talk. I would like to request the viewers to write the question and answer box. After completion of Dr. Shah's talk, the moderator will start question and answer. Please, Dr. Shah.
Thank you, Dr. Sohrab, for a nice introduction, and thank you, Dubai Pediatric Club, for inviting me for this talk. And I also thank Dr. Kalpana and Dr. Diari to moderate the session, and also Dr. Vivek for kindly agreeing to be the panelist. Today, I am going to talk about fits, fidgets, and funny turns from epileptologist's perspective. This topic is very close to my heart because as I have evolved from being a pediatric trainee and pediatric neurology trainee, and then a trainee in pediatric epileptology, I have seen how everything doesn't necessarily fit into the basket. What we teach and preach and or what we are taught during our training, and when you see in the practical world, more you train, more you gain experience, more you realize that how little do you know. So first thing first, some disclosures. I will be showing some videos during the presentation, and consent has been taken for using these videos exclusively only for teaching purposes. And I request all the audience not to individually video record these videos, because these are not for public sharing. I don't have any financial or commercial interest. To set the scene right, this is a conversation of a real phone call that one of my fellows received when I was supervising her back in Australia. There was a call from a regional hospital about what was described as a 3-month-old infant with focal onset seizures. And when my fellow asked what were the focal onset seizures, it was described to her as clonic movement of the left arm. My fellow gave an advice based on her training at the level to observe overnight, because the patient was already admitted to a regional hospital, video record the event if possible, and we will organize an EEG next day, and possibly, given the focal nature of the seizures, arrange an MRI as well. Patient overnight continued to have these episodes. Patient's parents were understandably getting worried. They asked the doctor in the regional hospital, pediatrician, to arrange an urgent MRI because they were worried there may be something wrong, like a tumor or anything else. On the way to the MRI suite, my fellow got another phone call, said that the patient is now having a cluster of seizures, and advice was given to transfer the patient to our hospital, which is the tertiary center. This is just to set a scene how information can be received from other person, and how important is it to get into a little bit deeper into the history. And I will come back to this phone call a little bit later. First, to outline what I'm going to talk about, I'm going to talk about some facts and figures. We'll do some definitions. I will highlight mainly with some case examples as to how challenging it can be to diagnose someone as having seizures and what are the diagnostic pitfalls. And I'll be more than happy to answer any of your questions. Now, non-epileptic events are very common. It's been widely studied across many different institutions and settings, many different countries. Roughly, the data from different studies is the same. About 1/3 to 1/4 of the events that are captured in epilepsy monitoring unit turn out to be non-epileptic events. There was a study done in Cleveland Clinic in Ohio, wherein they found about 15% of their patients admitted in epilepsy monitoring unit had paroxysmal non-epileptic events. And interestingly, 1/4 of them can have a concomitant diagnosis of epilepsy. What is to highlight here is that a child or an adult for that matter who has an established diagnosis of epilepsy, if they come up with a paroxysmal event of any nature, it should be individually evaluated whether that is related to their underlying epilepsy or it is a non-epileptic event. Similarly, another study found that about as high as 60% of paroxysmal episodes in infants less than 1 year were non-epileptic in nature. We've done a study led by one of my mentors, Dr. Anibai, in Sydney Children's Hospital, wherein we evaluated 666 children, a wide age range between 2 weeks to 17 years. And our figures were similar to overall figures. We found almost 1/3 of them had non-epileptic events that range from staring, parasomnias, or different type of movement disorders, migraine phenomena, or paroxysmal non-epileptic events, and other phenomena like self-gratification, apnea, or cardiovascular events. Let's talk about some definitions. And often sometimes people get confused between a seizure and an epilepsy. What is a seizure? What's not a seizure? Let's talk about some definitions. What do we call a seizure? Seizure is any transient symptom or sign that happens in response to an abnormal, excessive, and synchronous activity of a population of cortical neurons. Now, it's very important, especially important in pediatric population, to know that motor cortex comprises only a very small percentage of the total cortex. That means for a seizure to manifest as abnormal movement, it should either originate from the motor cortex or the seizure should propagate to the motor cortex, meaning thereby that in children, seizures can present without any motor movements, as we all know, seizures like absence seizures or focal onset seizures with preserved awareness. What is a non-epileptic seizure? Now, this term is a bit confusing because it says non-epileptic seizure. There's a reason why it's called non-epileptic seizure, because it mimics a seizure, but the underlying process is not from an abnormal, excessive, synchronous discharge from the cortical neurons. The other terms used are pseudo seizures, psychogenic seizures, and the preferred term, what I like, is psychogenic non-epileptic events. What is the syncope? Syncope is a transient loss of consciousness due to a cerebral hypoperfusion. Then what's the convulsion? And now this term is a descriptive term, which is often used for anything that involves jerking or stiffness. It can be used both for epileptic and non-epileptic episodes. It's an imprecise term, better to be avoided, but it's still used in context of convulsive syncope or febrile seizures, what are most commonly known as febrile convulsions. There is an interesting term I put in there deliberately, convulsive syncope, wherein a child has a convulsive episode, but it can be associated with some jerking movements because of cerebral hypoperfusion and secondary paroxysmal activity in the brain, what we will call as a convulsive syncope. Now, I want to run you through a brief journey through what is called a comprehensive evaluation of epilepsy. So it all starts with an event. We often get phone calls, as I described the one, and we'll come back to that in a little while. We get called, or we get shown a video, or we get described an event and we have to determine if that event is a seizure or not. And as I said earlier, it is very challenging. More you read epileptology, more you practice epileptology, you will see that everything is not always in black and white. But we have to all start with description of the event, getting the deeper details of the semiology, and because that is the basis of epileptology, despite advances in imaging, despite advances in EEG, the core of pediatric epileptology is studying the seizure semiology. Once we determine if an event is a seizure or not, we should ascertain what is the seizure type. Is it a focal onset seizure? Is it a generalized onset seizure? Or the onset is unknown? And if we determine what is the seizure type, we should then ask a question: does this particular patient meet the criteria for epilepsy? And there's been a revision in the epilepsy diagnosis, wherein previously we used to say anyone who has two or more seizures, unprovoked seizures, has a diagnosis of epilepsy. But now the revised definition, if someone has one epileptic seizure, and with the help of investigations, we can determine the chances of seizure recurrence is similar to or higher than those having two epileptic seizures, we can diagnose someone as having epilepsy even after a single seizure. And of course, if we diagnose someone as having epilepsy syndrome, then he or she meets the criteria for epilepsy diagnosis. And we don't stop here. Once we establish an epilepsy diagnosis, we want to see what is the electroclinical syndrome. If someone fits into a particular epilepsy syndrome, Dr. Saurabh highlighted Lennox-Gastaut syndrome. We need to know if someone fits into a particular syndrome like myoclonic atonic epilepsy, what was previously called as Doucet syndrome, because that has got implications on prognosis, implications on the line of investigation we take, and also implications on the treatment chosen. Once we establish an epilepsy syndrome, if we are able to, we should also look for an etiological diagnosis. Now, this thing is very important because establishing the diagnosis of epilepsy is different from finding the underlying etiology. And we should do both in parallel. And once we have all this information, we should then offer the best treatment for the patient. But we need to go through this from the beginning. What I want to highlight here, if as an epileptologist, if a patient comes to me with an established diagnosis of epilepsy, I should not be moving forward from epilepsy diagnosis down this ladder. I should be going back to the original event, try to find the details of the event, and then move forward again. And I will highlight some case examples as why this approach is important. So today we'll be only talking about the first step in the comprehensive epilepsy evaluation, and that we'll be talking about the events that may be in form of fits, fidgets, and funny turns. Let me play some examples. This is a boy who is having a laughter while reading a book with a lot of text. What is happening to him is something out of context. And if we look at this video, we'll clearly say it is something unusual. And if we do an EEG on this patient, it may be normal, but we know what is happening to him is clearly abnormal because it's out of context. It's got certain onset, certain offset. Most likely, it is a gelastic seizure. If we see something like this, in this patient, we see that patient is sitting, smiling, and all of a sudden has spasm, infantile spasm. And as a pediatrician, all of you will be alerted to immediately send this patient for an urgent EEG because this type of seizure is associated with neurodevelopmental decline. So it's quite obvious. And if you see something like this, and you will again see whether it's a focal onset seizure or probably a spasm. and you will immediately refer these patients to the neurologist or do further evaluation. So sometimes things may be very clear and there's no diagnostic problems, and these patients will most likely not be misdiagnosed, but the investigations would be done promptly. Let me go back to the phone call again. Phone call, we had a 3-month-old infant who was referred eventually to tertiary hospital with a history of focal onset seizures manifesting as clonic movement of the limbs, and they were clustering. And this patient was immediately came to the emergency department, and EEG was hooked up because that was a history that patient is having clustering of seizures. And you will see patient is having a jerky movement of the limbs that is asynchronous and is happening during sleep. What was missing from the history, though, which the person who was relaying the history did not comment and my fellow didn't ask, is that what is the setting? All these events were happening while the patient was asleep. And you all have come across events like this, what is described as benign neonatal or infantile sleep myoclonus. These are random, rapid, bilateral, often bilateral, but asynchronous. The catchy word here is asynchronous. They're always asynchronous. They may be forceful, sometimes they may be rhythmic, and maybe you may confuse that with clonic seizure, but they are always asynchronous. They may last for seconds to minutes, or even hours during sleep intermittently. They can happen in all stages of sleep, although they are more common during transition into the sleep. They disappear when the infant is woken up, but you don't have to do that all the time. They are not seen during alert wakefulness, and they do not stop on passive flexion as opposed to jitteriness. And EEG is often normal, but I should highlight often unnecessary. A good history is what is needed. Good history and the video of event makes the diagnosis, and there's no need for doing an EEG. This is another case about a 2-month-old who had onset of these movements in the neonatal period and was commenced on phenobarbital. Then continued to have these events, and another medication, levetiracetam, commonly known as Keppra, was added, and these were the movements. A routine EEG was done, which was normal before they came to us. What we noted that every time a physician touches the patient goes into the spasm. And all the episodes were stimulus sensitive, either to the tactile or to an auditory stimulus. Patient had a 24-hour video EEG monitoring where multiple episodes were captured and none were associated with epileptic activity. This is often misdiagnosed as neonatal epilepsy, but it is a condition called hyperexplexia. It is an exaggeration of normal startle response. Infants are often hypertonic with rigidity rather than spasticity, which is relieved by sleep. The common bedside test is the gentle tap on the forehead, and you will see excessive startle that doesn't habituate after repeated nose taps. The onset of excessive startle in later childhood or adulthood may be associated with antibodies to glycine receptors. These patients should not be misdiagnosed as epilepsy. I have seen 2 patients in the last 8 months who were on 2 anti-seizure medication with the diagnosis of hyperexplexia. It's often benign. Some children may have developmental delay, mostly related to the increased tone, and some patients may have underlying genetic mutation. Now, this is another case, a 9-year-old boy with history of epilepsy from early childhood, who was on sodium valproate. He continued to have the episodes. Again, he was commenced on levetiracetam because he continued to have seizures. There were no previous investigations available for review. When he came to us, we did an EEG, routine EEG, which was normal. We did a sleep-deprived EEG, which was also normal. So what we did is we took history in detail. The history was described as this child has a seizure and falls to the ground. But when we analyzed the history in detail, it was the other way around. He would have a sudden fall to the ground, followed by an episode of uprolling of eyes. He would often be pale with jerking of arms, right or left, sometimes stiffness, sometimes head extension. These events would last for 20 to 30 seconds, and patient would be sleepy afterwards and then recover back to normal within around 20 to 30 minutes. This is one of the episodes that was captured during the EEG monitoring. This is the patient. We, because it was clear from the history that the events are induced by traumatic stimulus, we inserted a cannula while the patient was being monitored. And I want to draw your attention not to the EEG, but to the ECG lead as I play this video. Look at the ECG lead, you will see that there is bradycardia, heart rate is slowing as he is looking and then there is a period of asystole for 6 to 7 seconds, and that leads to suppression of the EEG waves and then eventually leads to what looks like a tonic-clonic seizure. After a few seconds, the heart rate returns, EEG waves come back normal. He is a bit drowsy because of the event and eventually recovers after a period of time. I had another patient not long ago who was on 2 anti-seizure medications because he was having events which parents described as every time he's frightened, he will fall to the ground, look pale with uprolling of eyes, jerking of limbs. He was commenced on carbamazepine because he had an EEG which showed bilateral centrotemporal spikes, which is usually seen in what was described as benign Roranic epilepsy. Now it's called self-limiting epilepsy of childhood with centrotemporal spikes. He continued to have events, another medications were added. And when we took the history, the seizure semiology did not match with what is expected with a child who has bilateral centrotemporal spikes, because all his episodes were in awake state. They were happening when he was frightened. And similarly, in the epilepsy monitoring unit, we induced a painful stimulus after insertion of cannula. As he got frightened up, you will see a period of asystole. Soon, his heart rate is already started to become irregular at this stage. As he's frightened, he again has an asystole in here lasting for around 2 to 3 seconds. And both these patients have a diagnosis of reflex anoxic seizures, which is not a seizure in true sense, but it is a type of a syncope. Any unexpected stimulus leads to profound vagal discharge, resulting in dramatic drop in heart rate and transient asystole. Child often is pale with loss of consciousness. As with both our patients, will have decerebrate posturing and sometimes mimicking tonic seizure. Upon recovery, they may be emotional and fall into deep sleep for a few hours, and look extremely pale, but they recover spontaneously. Again, this, even if you continue with anti-seizure medication, they continue to have events. They should have a baseline cardiac evaluation. In most of the patients, cardiac evaluation is normal. Just mere reassurance is what is needed. Now, again, highlighting why it is important to go back to the main event, as I showed you in the slide where I described the journey a patient goes through during comprehensive epilepsy evaluation. We have to go back to the main event. Now, this is something that you would commonly see, repetitive movements. Repetitive movements are common. They are more common in neurodiverse children with autism spectrum disorder, but can also seen in children without any underlying neurodevelopmental problems. This is another example of stereotypical movement. Fidgeting, tapping, moving, clapping. So these are the two examples of what we would describe as stereotypical movement. The first example, this one, is a typical stereotype, which are repetitive, purposeless movements, more common, as I said, seen in neurodiverse children, can manifest as body rocking, head banging, or head rolling, can be interrupted or on distraction. Often there's an associated ADHD, and if these are also present in neurotypical children, these are called primary motor stereotypies. I showed you the other example. The difference between the two is that this second case, we evaluated the video of at least 10 or 12 episodes. They exactly looked stereotypical with the same sequence. That's why we admitted him to epilepsy monitoring unit. His routine EEG was normal. During the events, there is a slight sharp wave followed by suppression of EEG, but this EEG was not helpful because it did not show a clear epileptic activity. But our suspicion was very high about this being not a typical stereotypy. So we did pre-surgical evaluation. His MRI was normal. PET showed a hypometabolism in the right cingulate gyrus. So we ended up doing invasive monitoring. For those who are not aware, stereo EEG is a technique wherein we can implant electrodes deep within the brain. This involves thorough pre-surgical evaluation, pre-op imaging and post-processing, trajectory planning to avoid any vascular spaces, and then final evaluation of the data. So this is the trajectory planning, hitting the target areas, and this is the actual electrodes within the brain. And we found that there was intra-ictal discharges corresponding to the right cingulate gyrus, and we captured a clinical event with a precise onset in the right cingulate gyrus. This patient had, this is again zooming into those electrodes that were involved with clear onset in the electrode E, which corresponds to the right cingulate gyrus. This patient had successful epilepsy surgery and has been seizure-free for 4.5 years now post-resection. So cingulate motor seizures, as I said, these can manifest not as a typical tonic-clonic seizures, but they can mimic stereotypies. Often on deep questioning, you will see they have some altered awareness and behavioral changes during these events. If you look at multiple episodes, they will exactly look the same, which is not typically seen in usual stereotypies. EEG can be normal, and if there is a high suspicion of these being any form of seizures, they often need invasive EEG monitoring and further evaluation by epileptologists. Another event that often get confused is arousal parasomnias, night terrors, and frontal lobe seizures. And this is a table to highlight some differences between the two. For parasomnias, usually they occur within first 2 hours of falling asleep. Frontal lobe seizures can occur throughout the night. They are also more frequently within transition into sleep or from sleep to awakeness. Usually arousal parasomnias last longer, more than 10 minutes, and usually frontal lobe seizures are less in duration. Again, as we talked about cingulate seizures, parasomnias have variable features, whereas frontal lobe seizures, they are exactly more or less very similar in all episodes. There's no memory in arousal parasomnias, whereas there may be preserved awareness in frontal lobe seizures. This is an example of a patient who was diagnosed with night terrors because he was having almost 2 to 3 times in a week these events, and the routine EEG was normal. Even the EEG during the episode was normal. But when we look at the semiology, again, all the events were exactly stereotypical, and this is typical of a frontal lobe seizure. A normal EEG in these situations can be often misleading. Now, other important cluster of events that often get confused is psychogenic non-epileptic events, and to differentiate them from convulsive syncope and tonic seizures. This is the slide wherein you will see often that syncope may be associated with, there may be pre-syncopal symptoms. There is no warning in tonic-clonic seizures if it is a generalized onset, or if it's focal onset, there may be a warning. And psychogenic event, there may be some dizziness, but often there is no warning. You will see that there is variability in the amplitude, in the jerking, in the psychogenic events, and they often last much longer. And whereas in tonic-clonic seizures, they last for less duration, 30 seconds to 2 minutes often, and post-event there may be drowsiness that may last up to 2 hours. One important thing I want to highlight is jerking can be seen also in convulsive syncope. So presence of jerking if a child gives typical history of lightheadedness, presyncopal symptoms, then fall to the ground with preserved consciousness, followed by altered consciousness and jerking of limbs, you should more think about convulsive syncope than tonic-clonic seizure. And I should highlight that often this table is though helpful, but you should not make your judgment based on one single episode. I would strongly recommend evaluating multiple episodes and to see if there is a variability or not, and that's often very helpful. This is a patient who had onset of events, what she described as feeling unusual sensation in the tummy, followed by altered movements, altered awareness of the surroundings. She had a routine EEG, which was described as normal, but given the events were happening, she was commenced on carbamazepine. She continued to have multiple events despite addition of other anti-epileptic medication, and then she was referred to epilepsy monitoring unit. When we monitored her, we saw these events. She's lying on the bed, watching something on the phone. And she says she felt something. She will press the button. And now she started shaking her legs and the hands. She's saying no movements of the head and pursing of the lips and repetitive movements of the hand. All right. So as I said, she was initial diagnosed with focal epilepsy. Then when she was having these events, she was diagnosed as having paroxysmal non-epileptic events. Now, when we analyzed her in epilepsy monitoring unit, we captured around 12 events. They were all exactly the same. She would feel something, then she will have what looks like on surface of it as a non-epileptic event. But all the 12 events were exactly stereotypical. So we thought it is not a non-epileptic event. These should have a further evaluation. This is her ictal EEG, wherein apart from muscle artifact, you do not see any much appreciable epileptic activity. This is her MRI PET co-registration that shows area of reduced hypometabolism in the left temporal lobe, which was her dominant hemisphere, which you can see in the sagittal image as well. We planned a stereo EEG and targeted the areas of concern. We did a robotic stereo EEG in this case, wherein we can measure the coordinates and exactly have those values inserted to know exactly where the electrode will be inserting. So we inserted different electrodes, and these are the position of the electrodes on the surface of brain, and this is the actual patient photograph with the electrodes in situ. The patient was monitored for 3 days. We again captured 6 clinical seizures and 21 seizures that were subclinical. And I just want to highlight. So you will see this seizure.
My dad's like it. His good friend is all the people that does that stuff. I mean, he's throws out all the material.
Now we are monitoring her in epilepsy monitoring room. At this stage, we have already detected that she is having a seizure based on the stereo EEG, but she is unaware of this.
What's your name?
At this stage,
Seminole.
she's responding appropriately.
Remember the color blue, okay?
Now she has similar event to what you saw previously in the surface EEG recording where her EEG was
What color
normal.
is it?
You will see the 2 episodes are exactly similar: shaking of legs, shaking of hands. What we saw is that there was a clear onset in the perirhinal cortex, and as the seizure propagated to different areas during this time, she did not have any clinical symptoms. As the seizure propagated to insular apex, she had pursing of lips, which corresponds to the function of that part of the brain. As it went into temporal pole, she had some unusual feeling. It went to entorhinal cortex and anterior cingulate. As I described earlier, the cingulate motor seizures manifest as stereotypical movements, and she had stereotypical movements at
Sorry,
this.
Dr. Shah, I'm interrupting. 2-3 minutes.
Yes.
Thank you.
Then it went to amygdala, and we evaluated that she had an epileptic seizure, although what looked like a non-epileptic seizure. Because of comprehensive evaluation, we could determine it's an epileptic seizure, which starts in the area of the brain that does not necessarily produce any symptoms, apparent symptoms. As it spreads to other areas of the brain, we get clinical symptoms that correspond to the function of that area. What we did in this case is a stereotactic SEEG guided thermocoagulation by zapping the electrode B1 and B2, and the patient was seizure free for 4 months post procedure. But given she had an extensive area of hypometabolism, we proceeded with mesial temporal resection, and patient has been seizure free for last now actually 10 months. What I wanted to highlight today is the misdiagnosis of epilepsy is very common. It varies substantially with estimates, and the range is from 2% to 71%. Even the patients who are seen by neurologists or by general practitioners or by pediatricians, all the misdiagnosis varies across the spectrum of the specialties seen. Epilepsy is associated with an increased risk of morbidity and mortality, but there is also significant risk associated with misdiagnosing epilepsy. As Dr. Saurabh quoted Hippocrates, do no harm. We should be very careful in diagnosing epilepsy. If the data is not sufficient, we should refer them for proper evaluation. As it is important to diagnose epilepsy, I think equal consideration should also be given to misdiagnosing epilepsy. So take-home message is thorough evaluation of recurrent paroxysmal events is key to the correct diagnosis. What I call deep phenotyping of seizure, or that matter any event, into seizure type and epilepsy syndrome is essential. Epilepsy evaluation is a complex process. Going back to the event, semiology is essential before moving forward. Someone who comes with an established diagnosis of epilepsy, as an epileptologist, should always go back to the main event. What I want to highlight also is a normal EEG does not rule out epilepsy. Similarly, if someone has an abnormal EEG, that abnormality should correspond with the event in question. And that's why semiology EEG concordance is essential for the diagnosis of epilepsy. Thank you very much for patient listening, and I'll be more than happy to answer any of your questions.
Thank you very much, Dr. Shah, for this excellent and informative presentation. I'm sure all viewers benefited. I would like to request all viewers to write their question in the question and answer box so that our moderators, they will take the question. Now I would like to request Dr. Vivek, consultant pediatric neurologist at Medcare Hospital, Dr. Kalpana Sengupta, consultant pediatrician and head of department at NMC Specialty Hospital, secretary of the club, Dr. Diari Muhammad, consultant pediatric surgeon at Al Jalila, chairman of the academic affairs, to join us with Dr. Shah, and I would like to request Dr. Kalpana to start the session for discussion. Thank you very much.
Thank you, Dr. Sohrab. Thanks, Dr. Shah, for this very nice lecture. And before we move further, it's very important progressing from backwards from your last slides. Avoid missing. What, in your opinion, leads to pediatricians or doctors making this misdiagnosis commonly?
I think in my practice, and there are many factors, the most important factor is requesting an EEG for an event that is not a seizure in the first place. Because invariably, I mean, today I saw a patient in the clinic who, when the EEG was requested by a behavioral therapist, and they had not, I said, and she came up with an abnormal EEG with centrotemporal spikes. Now we know that abnormal EEG can be seen in variable percentage of normal children, or there, especially in pediatric practice, it is very important that first of all, judicious use of EEG as a diagnostic tool is one. Knowing that abnormal EEG patterns, or what could be considered as an acceptable EEG abnormalities, distinguishing epileptic abnormalities from what we call non-epileptiform abnormalities in EEG. That's one point. Second point is, often I have seen that patients are referred to adult neurologists, not for consultation, but for EEG. And Dr. Vivek will agree with me on this point, is interpretation of pediatric EEG is much more complex. And I would feel satisfied if I read a report from my pediatric neurology colleague. Adult EEGs are more or less straightforward, and our adult colleagues may not be aware of subtleties in the pediatric EEG interpretation. That's one. Third important point, which leads to misdiagnosis of epilepsy, is not equating an abnormal movement with an abnormal EEG when it doesn't match. Say, for example, I saw 2 months back, I saw a patient who had a tremor, which clearly looked like a tremor, went on, had an EEG requested by a neurosurgeon, and it was reported by an adult neurologist who said bilateral centrotemporal spikes suggestive of focal epilepsy. And this patient ended up being on anti-epileptic medication. So to summarize, non-judicious requisition of the EEG in the first place, and EEGs interpreted by non-pediatric neurophysiologists. Third is not giving heed to the EEG semiology concordance. These are the three main factors that lead to the misdiagnosis of epilepsy.
Thank you. Dr. Vivek, would you like to add something from your experience?
Yeah, I mean, so in terms of EEG, it has not great specificity or sensitivity. That's the problem, you know. And there is nothing like a black and white test in epilepsy that can diagnose epilepsy. Because if you see the multi-axis classification which Dr. Ubaid had just put forward, the first thing is the episode itself, you know, whether it looks epileptic or non-epileptic. That's very important. Often we get, you know, just EEG to
Vivek, can you increase your voice, please? Can you raise your voice?
Yeah. Can you hear me now?
Yes.
Yeah. So we get patient with EEG often, you know, just because he had an episode or the child has an episode, and to diagnose if it is epilepsy or not. Sometimes I just get the weird request, this child is referred for epilepsy. The history is very important, as we always say. So if you're not sure, send the patient back, ask them the video, just be clear with what you're looking for. If you think it's epileptic, and again, what he just, you know, mentioned, the how to do EEG and all that is a next different story. So I think, yeah, we should be using EEG very wisely and not misuse it often.
Okay. So from your point of view, are there any specific features you look for when you are looking at the event, which would tell you this is a true seizure?
Sure. Very important is the setting, often not asked for. In what setting did it happen? Was the child sleeping or awake? Was the child playing? What was the child doing just before the event happened? That's very important, an often ignored aspect. Then who witnessed the event? I would often ask who witnessed the event. And I would like to talk to that person directly, if possible. Even if it's a school teacher, I would pick up the phone, ask them, give me contact details, or obviously after due permission, I will talk to the person preferably, even if it's a sibling, if it's a 10-year-old who watched it. I would take history from someone who's witnessed the event. Then to the child, I would ask, what was the first thing that they noticed? Did they feel something happening before the event? To the witness, I would ask, what alerted you to the event? Seeing what was the thing? When you first saw, were eyes open or eyes were closed? Were limbs stiff or they were loose? Was one-sided affected more than the other? Was there incontinence or not? And as I said, once what happened to the breathing? What happened to the color? Was it not necessarily blue? Turning pale is equally important. Was there pallor? Was there cyanosis? All these things are important. Was there incontinence? And then what happened after the event? Was there a spontaneous recovery or not? And then if there are multiple events, then were all these events stereotypical or not? I think that's again, the first and the last thing is often ignored aspects, the setting and the variability or absence of variability.
Dr. Ubaid,
Yes.
When stereotypic movement should be investigated?
You asked a very good question. I showed two videos in the same slide. One was a stereotypical movement in a child with a background of autism spectrum disorder, who was, if you looked at his face, if you clearly observed the video, he was happy, alert. He had, although he had limited communication, but there was a lot of non-verbal cues in his communication. He was communicating, he was interactive, alert. There was no disruption. There was no change in his behavior. Whereas the second patient, that was a cingulate motor seizure, you would see that he was lying on the bed. All of a sudden, there was no setting for it. All of a sudden, he started clapping, tapping, and there was alteration in his behavior. And when we examined multiple episodes, they were all exactly following the same sequence. Whereas stereotypical movements, they may look more or less similar, but they will not follow exactly the same sequence. So to answer your question, if stereotypical movements are too stereotypical, they are not stereotypies.
So by EEG, or you would go for CT, MRI, or any other invasive?
I think again, a very good question you ask. Often because we're talking about cingulate motor gyrus, which is in the mesial side of the mesial. So often their EEG is normal because it's on the middle and we're recording from the surface. EEG can often be misleading. Children with, as I said, two stereotypical stereotypies need complete evaluation. We should not stop at a normal EEG in these situations. So if they should have admission to the epilepsy monitoring unit, we should capture multiple episodes, analyze the semiology, look at any subtle abnormalities on EEG, which would not be picked up either by a routine or a sleep-deprived EEG. They need to be admitted to the epilepsy monitoring unit. And if there is a high suspicion of this being cingulate motor seizures, then they need proper epilepsy protocol MRI. Other thing I want to highlight here, often I get patients who have a normal MRI, but in MRI, the standard MRI has 5 millimeter gap between the two slices, or 3 or 4, if it's a better quality. The type of MRI that we do for epilepsy, first of all, we give them the area of the suspicion, say for example, mesial frontal lobe, and we do finer cuts in that area, which are less than 1 millimeter, often 0.6 millimeter slices. So a normal MRI will not rule out any subtle abnormalities on these patients.
There's a question from the Q&A. Doctor wants to know, does it help to differentiate seizures from stereotypies in autistic kids if they are exclusively diurnal, when EEG is within normal during the event or showing myogenic artifact?
Yeah, as I showed in our patient also, EEG predominantly showed myogenic artifacts. If they are happening both during day, and even if they are happening at night, someone is waking up and having these stereotypical movement, it is highly suspicious of this not being stereotypies. Stereotypies should not happen during sleep. And irrespective of whether the child has autism spectrum disorder or the child is neurotypical, the chances of them having seizures, in fact, it is higher in a child who has autism spectrum disorder. I think they should be evaluated.
I just wanted to ask you, you use the term neurodiverse and neurotypical. So can you just elaborate on this? What exactly do you mean?
Thank you for asking this question. I personally do not like calling children autistic, or even question you asked, someone said autistic children. I don't personally like. I think the preferred terminology, and hopefully in near future, in coming years, will be all talking about neurodiverse and neurotypical children. So there are children who have unique capabilities, strength. Every child has his or her strength, weaknesses, challenges. Those who are outside the spectrum of what is considered normal by our standards, they are neurodiverse. And neurodiverse may be extremely intelligent, they may have exceptional memory, they may have problems in the social interaction, they may be more hyperactive than a normal fidgety boy. So that's why use of term neurodiverse. I think worldwide we are moving more towards using term neurodiverse and neurotypical rather than labeling children as autistic or hyperactive.
Okay.
Dr. Ubaid, any convulsion we are seeing, or other colleagues, pediatricians, seeing a lot of febrile convulsions in the emergency? And when you will say this febrile convulsion, or sometimes we have repeated cases of febrile convulsion, any highlight on medication?
Sure. First of all, just put it right, the fever is one of the commonest triggers for a breakthrough seizure in patients with known epilepsy. So fever is one of the commonest, but in an otherwise normal child with no prior history of seizures, if they fall into the age range of 5 months to 5 years, and if the seizure happened only during febrile illness and it was typical, mostly generalized, tonic-clonic, resolved within 5 minutes, and we identified the cause of fever and the fever was documented, we should still diagnose them as having febrile seizures and do not do any investigations, including EEG. This is important because, as I said, children with without any problem, normal population up to 10% can have abnormal EEG. But children with febrile seizures are more likely to have abnormal EEG. So that would not change our diagnosis. A typical febrile seizure should be left as such because the chances of subsequent seizure, subsequent diagnosis of epilepsy in a typical first febrile seizure is 2 to 5%, which is only twice as general population. Because general population, everyone has a chance of having seizure in a lifetime 1 to 2%. Now, to put it in clinical perspective, and this is very important, if someone has a single febrile seizure, the chances of them having subsequent seizure is 40%, right? But still, we don't start them on anti-seizure medications, despite having 40 times the chance of having seizure than general population, because there is 60% chance of not having a seizure. Now, with a febrile seizure patient, there are 95 to 98% chance of them not having epilepsy. So typical febrile seizure should be left alone. If the seizure is atypical, especially if it is focal onset, or if it is much prolonged, they should be investigated, preferably with an MRI, especially if it is recurrent. Other indication of investigation is if it is the prolonged, if it is more than 15 minutes, it could be one of the first signs of SNC2A, SNC1A channelopathy. So they should be investigated for underlying genetic mutation.
On this, there is a question from Dr. Amir saying that many children who develop fever just after the fits, should it be labeled as febrile fits?
It's a very, very important question. Very nice question. Because as we all know, the fever can be the first manifestation of an illness. It is often the case that the fever would happen after. I know there are some arguments that the physical fit or can also generate increased temperature, but that is usually very short lasting. So most often, children with febrile seizure, the seizure would be the first manifestation and fever would develop afterwards. It is the rapidity with which the fever rises that causes the seizure rather than the actual fever itself. So it is common. I wouldn't be worried about if the seizure if the fever happened after the seizure, but if it is happening very frequently and the seizures are prolonged, as I said, then they should have testing for SCN1A gene mutation.
I think I agree, because that's often very typical story. You get the seizure and then the child has temperature. And that's to do with the rapidity of how quickly the fever rises. And not to forget, it's a core body temperature, which causes the febrile seizure, not the surface temperature. What we taste often is the surface temperature. But that's the reason why we don't give any cutoff for the, the fever. Parents are always told, control the fever and the seizure will go away. That doesn't help, honestly, So the child will get it.
What would be...
May I interrupt Dr. Kalpana to ask one question? Very often we see parents, they do a sponging, especially cold sponging. There was a time they used to put the child in ice, ice box. I read somewhere this mere sponging with cold water may trigger itself seizure. The mechanism, they said, the heat usually comes out of the body. When you do cold sponging, did heat goes back instead of going out. So what is your opinion on this?
Again, a very important and common practice. It is practiced mostly in maybe this part of the world due to cold sponging for comfort. If cold sponging is done for comfort, that's a different. But to prevent the febrile seizure with cold sponging or cold bath is definitely not recommended at all. It can, in fact, increase the core body temperature and increase the chances of febrile seizures. In fact, I mean, in all Western guidelines, even treating the fever promptly is not generally recommended. It's only recommended if the child is feeling miserable. So neither the treatment of fever nor cold sponging is recommended. But if the child is having a history of febrile seizures and if he has a febrile illness, it's okay to give antipyretics, but for his comfort, but it would not necessarily decrease the chances of them having febrile seizures.
What is the consensus regarding clobazam? Lot of pediatric neurologists are prescribing it. So
I think guidelines are very clear. There's no role of using clobazam in prevention of febrile seizures. Same argument as I said earlier, that the first of all, if the seizure happens for 5 minutes, there is ample evidence to suggest that if the seizures stop within 5 minutes and there is no hemodynamic compromise, airway compromise, it does not cause any brain damage. And to use clobazam, the benefits as per evidence do not outweigh the risks. So there is no established guideline to say that it should be used. In my personal opinion, there is no role for clobazam in febrile seizures, or for that matter, any prophylactic, what used to be called prophylactic anti-epileptic medications. In the argument in developing world is that if the child lives far away from the hospital, what to do? If that is the case, if the seizure lasts more than 5 minutes, if it's a prolonged seizure for any matter in children with epilepsy or those who are known to have prolonged febrile seizures, there is some role of using nasal or buccal midazolam to abort the event if it is a prolonged one, to be used, but not prophylactically, only to stop the prolonged seizure.
Right. And the next question would be about the timing of EEG in afebrile seizures. When would you do it?
Excellent. Good question. I think it is a moving space, to be honest. As I said, with the revised diagnosis of epilepsy, it depends on the clinical context. Earlier, the old school thought is that if you have a one seizure, you are allowed to have a one seizure, come back if you have second. I think we are moving away from that thing. If you have a focal febrile seizure, any person with a focal febrile seizure should definitely have an EEG, especially with EEG with sleep. That's one. Second, say for example, if a 13-year-old comes to me with the first generalized tonic-clonic seizure, if I take the history, they often have history of myoclonic jerks. This patient is almost 99% probability have juvenile myoclonic epilepsy, which is a lifelong epilepsy. And if we do an EEG on them and we see photoparoxysmal response, this is one of the reasons why the epilepsy definition was changed. So in this situation, we can diagnose this child, this particular example, as having epilepsy even after the first seizure, because the chances of subsequent seizure is definitely more than 60%. Similarly, if I see a patient with focal onset seizure and I do an EEG which is clearly showing focal abnormality, I do an MRI which is showing focal cortical dysplasia after the first event, I do not I establish the diagnosis of epilepsy in this patient after the first seizure itself and start them on medication.
May I interrupt? I ask one question, Dr. Shah. I mean, while taking history, there was a time I was saying if family history is there, it's a good sign. Is it not good or bad sign somebody is having family history of seizure?
Yeah. So if you have family, it's a very tricky question. I don't think generally we'll say family history is a good thing. But if someone is having febrile seizure and there is a family history of febrile seizure, you are more reassured it is more likely to be a febrile seizure. In that situation, it's a good thing. If you are having a family history of epilepsy, I think getting to know what type of epilepsy, was it a childhood onset, was it a late onset? If it is a childhood onset epilepsy, it can help you in establishing the etiological diagnosis. Because now, earlier, mostly generalized epilepsies used to be called idiopathic epilepsies. But now we know that almost half of them are genetic. We may or may not be able to identify the genetic reason. But moving even focal epilepsies, now we have another set of focal genetic epilepsies. Classical example being mutation in a gene called DEBDEC5. And you can have multiple family members with different seizure types. So sometimes it is helpful in ascertaining what is the underlying etiology. I don't necessarily think someone having a family member with epilepsy is generally a good thing. So you have two family members with epilepsy in a family. So it's a more challenging for the family.
Dr. Vivek, can you give us some insight into the genetic diagnosis? Which are the cases we'll consider for genetic diagnosis?
So, I mean, just going back to the context of febrile seizure, we talked about how uncommon or atypical febrile seizure. Now there's like, GEFS plus, what we call it as, or genetic epilepsy febrile seizure plus. These children are not very typical febrile seizures. They come with, multiple different types. So any unusual kind of thing, we talked about the family history as well. And, Ved has given a nice example. So if you have a good pedigree chart, having multiple people affected in the family, you sometimes get to know the inheritance pattern or, the flavor of genetic epilepsies. So that's another thing. Often the children with epilepsy, now the term which we used to call it as epileptic encephalopathy, just not epilepsy, it comes with a package of developmental impairment, learning difficulties, or let's say neurodevelopmental issues like autism, ADHD. So there's kind of a package the child has, and you start suspecting the child is not straightforward just idiopathic epilepsy. There's a flavor of genetic epilepsies. So, all these children, I often have low threshold these days to go for genetic because, we're getting more and more diagnosis in children. And the advantage of, living in today's time is giving them precision medicine. Now we can go, that's another kind of topic of discussion, how we can cater the treatment for these children, to sometime with a good prognosis, to be honest. So I think any child who doesn't fit in the idiopathic, so if I go back to the ILE classification, you have structural causes where you have something in the brain, you pick up in the MRI, like you give the example of focal cortical dysplasia, whatever. You can have autoimmune or immune mediated epilepsies, you have typical history, you can have infection related, and you can have, sometimes you don't know the cause, but these are the don't know the cause. And if you have the genetic flavor, you must get to the bottom of it. And these days, we had the panel, we do the whole exome sequence, and the tests are much cheaper now. So yeah, we should keep low threshold these days for these children.
As far as
there are a lot of questions on the first line management. Yeah, first line management of epilepsy. I mean, medication wise, what's the first drug to be used?
Yeah. So if I go back to that slide wherein I said going from the event to the type of the seizures, establishing epilepsy diagnosis, establishing epilepsy syndrome, and then etiological diagnoses, and then treatment. Treatment option is all. We cannot determine, although we may start someone with a medication while we are evaluating, but ultimate, the best medication is once we go through that process to determine what is the best medication for that particular individual. Generally speaking, what we should consider, what I consider in evaluating the best first line treatment is patient's age, patient gender, likely etiology, not established, but likely etiology, and whether the patient has any underlying epilepsy syndrome. At least in my first or second consultation with a patient with epilepsy, I would try to ask these questions to myself. Some are very obvious, age and gender. Other is like seizure type, and if there is an underlying epilepsy syndrome, because these do not need much investigations, just need an EEG and the detail of semiology. Giving an example, traditionally speaking, I think all of us, when we were in medical school, we say generalized epilepsy, first line medication is sodium valproate, focal epilepsy, first line medication carbamazepine. That stands true even now on most of the cases. But as I said, we have to consider gender. 13-year-old, 14-year-old girl with first onset of generalized seizure most likely has juvenile myoclonic epilepsy based on the EEG. We would avoid sodium valproate. We may use lamotrigine as a first-line medication. Similarly, a child, Dr. Vivek mentioned about genetic diagnosis and precision medicine. If we have a neonate, otherwise well neonate, without any history of hypoxia, and develops seizure from nowhere on day 2 or day 3 of life, and the EEG is showing multifocal activity or normal or even normal, this patient has benign neonatal seizures, and most of them have a channelopathy, either KCNQ2 or some sodium channel. They respond beautifully to minuscule doses of carbamazepine. Now, if I say in general, carbamazepine as a drug for neonatal seizures, everyone say, what are you talking about, right? It's not a common drug used for neonatal seizures. But in this situation, again, focusing on what could be the underlying etiology, what could be based on the information is important. Similarly, example, if someone is having head drops and myoclonic jerks, previously well child, normal development till 2 to 3 years of age, this patient most likely has myoclonic atonic epilepsy, or what was called Douze syndrome. And in this situation, 50% have mutation in glucose transporter. There is also a recommendation to use ketogenic diet as a first-line treatment, not for refractory epilepsy. First-line treatment for this kind of epilepsy. So it all depends on these factors what I outlined.
So when you consider epilepsy surgery,
yes, I think very important. This is very close to my heart. So, in my opinion, I'll tell you the guideline and then my opinion as well. So, guideline is any patient who has drug-resistant epilepsy of any kind should have comprehensive epilepsy evaluation and should be considered for epilepsy surgery evaluation, not epilepsy surgery, epilepsy surgery. So drug-resistant epilepsy is defined as if someone fails two appropriately chosen medications, right? Now, I'll tell you my view. I saw a 6-month, one of the second video, or in the line with third video, I showed you example of a gelastic seizure and infantile spasm. That particular patient presented at 7 months of age with infantile spasms. We did an EEG, it showed focal area changes in the right posterior region. We did an MRI of this patient, we found focal cortical dysplasia. Now, everyone, all my pediatric neurology colleague and all the pediatricians would know infantile spasm, very difficult epilepsy, devastating epilepsy, leads to West syndrome, neuroregression. Now, this patient was started on vigabatrin for a brief period of time, Now we know what is causing infantile spasm. We took this patient to epilepsy surgery even after first anti-seizure medication, right? And this patient had epilepsy surgery. By the time the patient was 1.5 years, patient was not on any medication with normal neurodevelopmental outcome, normal and no epilepsy and normal EEG. Now, in my opinion, any patient with focal epilepsy, except the one that are self-limiting epilepsies like benign Roland, what used to be called benign Roland epilepsies. Apart from the self-limiting epilepsies, all focal epilepsies should have evaluation for the underlying cause. Means they should have a comprehensive epilepsy evaluation to identify the cause. We may not proceed with epilepsy surgery, but they all need to have the evaluation to identify the underlying cause. And going ahead with epilepsy surgery is an individual decision based on weighing the pros and cons. That's for focal epilepsies. For generalized epilepsies, if any patient who has refractory epilepsy and is on 2 or more anti-seizure medications, and we do not find any resective cause for epilepsy.
How long? 2 medications for how long? For how long?
For a reasonable period of time. There's no defined thing, but as long as you have ensured the compliance and used it for, I would say 2 months, 3 months, you don't have to. There is those I was talking about generalized epilepsies who do not have underlying cause for resective surgery. These should be considered as candidates for ketogenic diet or vagal nerve stimulation, one or the other, or one after the other.
What is the success rate of ketogenic diet?
Success rate of ketogenic diet
in these cases?
Success rate of ketogenic diet leads to significant improvement in seizures in about 1/3 of patients. Now, and some improvement in seizures in another 1/3. That means response rate is around 66%. Now, as opposed to if someone is on 2 anti-epileptic medication and you add a third, the chances of any significant improvement in seizures is less than 5%. Less than 5%. So that means after 2 medications, adding in subsequent medication, 3rd, 4th, and 5th does not result in seizure freedom.
May I ask a question? If question is not there, just
so what actually? Yes. Sure.
Yeah, Kalpana, if you allow me. Suppose in a crowded,
Yes, doctor.
In a crowded OPD like yours, Dr. Shah, if children are there with high fever, one of the concern of nurses are there, fever is there, let us give something if some seizure happen. See, suppose if a child is children are waiting with high fever. Now, if suppose you don't give fever medicine, child develops seizure, or what is the relation between the fever and fever medication and seizure? Because this is a commonly believed that if you don't give fever medicine, child will get seizure. And if you give fever medicine, it will stop. What is the latest? Because many our viewers, they have this question in mind, especially for our nurses.
Sure. So in a patient, there are 2. In a patient with established diagnosis of epilepsy, if patient is having fever, we should make an attempt to reduce the fever because fever can act as a trigger for seizures, those who have established epilepsy. The patient who do not have established epilepsy, fever should be, the guideline is the fever should be treated only if the child is feeling uncomfortable. Fever is a normal response to, and we should try to identify why they are having fever.
But it's not necessary to immediately treat the fever to avoid the seizure.
No,
that's right. I think general pediatricians are more capable of answering this question than me. But my understanding is that reducing the fever rapidly would not necessarily prevent the febrile seizure from happening.
Dr. Vivek,
and I was just talking about, we're talking about general population and not with the children who are prone for febrile seizure. In general population, no such evidence unless the fever is because of encephalitis, meningitis like recent. You know?
Yes.
So one question from Dr. Hanin, which type of neonatal seizures responds better to Tegretol?
Doctor, you spoke about stereo EEG.
Sorry, I will answer.
Which type of neonatal seizures responds better to Tegretol?
Sure. Good question. I alluded to it briefly, but I'll elaborate on it now. So if a neonate has a normal antenatal course, born at term without any perinatal complications, and is normal on examination, and this patient, if they develop seizures without any other reasons, and the child continues to examine well in between the seizure, it is highly likely that they have one of the channelopathies, either KCNQ2 or SCN2A, like those. In these patients, obviously an EEG should be done, which could be either normal or show multifocal epileptic activity. If it is not showing any signs of what we call neonatal epileptic encephalopathies like Otara syndrome, if they are brief seizures, multifocal or normal EEG, this is the phenotype that are most likely have what is called benign infantile neonatal seizures. And more than 50% of them respond to medications on sodium channels. I would go to an extent of using carbamazepine or oxcarbazepine as a first line treatment for these, and also send genetic testing to confirm the diagnosis. Often the mistake people make is they wait for the genetic testing. And I think I showed one of the cases in the American Hospital Conference who was on 5 anti-epileptic medications before it was transferred. And then as soon as carbamazepine was started, suspecting that what the diagnosis would be, all seizures stopped and we were able to wean them off medications. And later on, the genetic testing will come 3 weeks later. Later on, we can get the confirmation of the genetic diagnosis. So to answer your question, a well neonate who is having brief seizures and in between the examination is normal, highly likely fitting with the phenotype of benign neonatal infantile seizures, and carbamazepine should be considered, if not first line, but at least second line agent.
There's a question from one of the attendees. How long should we wait after a seizure in a patient with post status?
How long should we wait?
Yes. How long should we wait after a seizure in a patient with post-ictic drowsiness to think about ongoing non-convulsive status epilepticus?
Again, very important question. In another two scenarios, if it is a patient known to have refractory epilepsy with lot of seizures, then that's a different, I assume we are not talking about that. We are talking about someone who presents with seizure and then is having prolonged. No. It depends on the duration of the seizure. It depends on the duration of seizure itself. Longer the duration of the seizure, longer you are likely to have a post-ictal drowsiness. In a typical 5-minute seizure, if the seizure is assuming to be generalized tonic-clonic, the post-ictal drowsiness can last anywhere between 30 minutes to 2 hours. It's a rough guide. It's a rough guide. If the neurological examination is normal, we can wait. We can let them sleep and let them wake up when they are awake. If you have prolonged drowsiness and beyond that period, trying to wake the patient up. If they are not waking up or they are not responding to the questions appropriately, then you should consider non-convulsive status.
The last question in the box, is arousal parasomnia synonymous to night terrors?
Yes.
Another question, should child with focal febrile seizures needs prophylaxis?
No, they need evaluation for what caused the focal seizure. They need MRI more than EEG, preferably both, especially a sleep EEG and an epilepsy protocol MRI. And if that points to the etiology, then we can either establish the diagnosis of epilepsy or leave the diagnosis of focal or atypical febrile seizure, and they do not need prophylaxis if the epilepsy diagnosis is not confirmed.
But if you allow me to ask one question, Dr. Shah, sometimes we see in a text is written fit, seizure, convulsion, epilepsy. When appropriate to use these terms?
Good. The most reliable term to use is a seizure for anything that happens in response to abnormal brain activity. The term fit or convulsion should be avoided, in my opinion. Now, second thing is when to use epilepsy. So epilepsy is first we have to establish the event that happened was a seizure. That is very important. Once we establish the event itself was a seizure, in other words, it was secondary to an abnormal brain activity, which doesn't necessarily need an EEG, but just evaluation of the semiology itself may point to whether it was a syncope or a seizure. Then once this patient either had 2 unprovoked seizures 24 hours apart, that establishes the diagnosis of epilepsy irrespective of the result of EEG. Irrespective of result of EEG, the EEG is not needed for diagnosis in such situation. Or if we have one established seizure, and with the help of investigations like an EEG and MRI, we establish that the chance of having subsequent seizure is more than or equal to someone having 2 unprovoked seizures. That means 60%. We can diagnose that person also having epilepsy. We use a term epilepsy. Third thing is, if we diagnose someone as having epilepsy syndrome, someone came with a seizure, first seizure that happened at night, 30 minutes after going to sleep, we do an EEG, it shows centrotemporal spikes. We establish the diagnosis of epilepsy in this patient, which is a self-limiting epilepsy of childhood. Now, one important thing I want to highlight here is, although establishing the diagnosis of epilepsy is linked to the treatment, but they are not mutually interlocked. We can diagnose someone as having epilepsy and decide not to treat. For example, first episode of what used to be called benign neurogenic epilepsy, now called self-limiting epilepsy of childhood centrotemporal spikes. We establish epilepsy diagnosis, but counsel the parents that we will not start the medications at this stage. So to answer your question, we should avoid all terms except use term seizure and epilepsy that I have defined.
One more question, if moderators allow me. See, this is a nightmare for parents having a child with seizure. Febrile seizure, very common, every day we see. Now, if a child repeatedly gets febrile seizure, let us say 3, 4, I mean, really, parents at 2 o'clock midnight, they rush to the hospital. I was reading, I think Dr. Kalpana is also aware, one paper with Dr. Udani, I think that 30% of the Asian subpopulation, they respond to that frisium or clobazam. Now, what is the opinion on this? Because, I mean, genetically, even parents having children frequently getting this episode. The role of this drug, because as Dr. Kalpana said, many doctors are using to clear, because this is a forum, experts are there. So many, they have this question. Would you please enlighten us on this?
Sure. First of all, I think the most important thing is confidence in the diagnosis. If I am confident what I am dealing with is a febrile seizure and nothing else, that's one. Then second important thing is patient education. Education to patient, and obviously in this situation, their parents, is that giving them evidence that a seizure that happens, what do you need to do? What do you need to do? Lay the child on the side, don't panic, turn the child on the side, make sure there's no danger around, and comfort the patient. If you turn them to the side, airway will remain open. Don't try to open the mouth. Most seizures, 95% would subside within 5 minutes, and it does not cause any brain damage. I think saying this preemptively rather than reactive to the parental concern is very important. So saying this, and this I tell to my patients who have epilepsy, and they do not need to come to the hospital. I say, if the child sleeps afterwards, let them sleep. That's the best thing you can do for the child. And having this reassurance is very, very important, and giving them data about how it's been established that it does not cause any brain. They're worried because they think that every seizure causes brain damage. And that is definitely not the case. I will again reiterate, there is no evidence whatsoever. There is no evidence whatsoever for using prophylactic clobazam in these patients. And often, as one of the questionnaires asked, that fever happens after the seizure. So seizure is, how would they know to give clobazam when the seizure has happened? And as all of us know, in a typical febrile seizure, for one febrile illness, there will be only one seizure. So that's already happened. So giving clobazam afterwards is again futile. So as far as evidence is concerned, you may use for parental comfort and other things, or your own personal satisfaction. But as far as evidence is concerned, there is no evidence in support of this. I usually use parental education on this. Dr. Vivek has some comment.
I think what I feel is the use of emergency medicine is a bit less. Even when the patient is referred to the pediatric neurology, we often see, I don't see any harm. I know the febrile seizure will subside within few minutes. But often parents feel that confidence, okay, I have something, to control if it happens. I have created the epilepsy passport for schools. We have given the medicine in the school. So that gives them more confidence. Because what happens is, if the child goes for the first time in ABC hospital, the hospital will admit, they will investigate, they'll start doing the same thing again and again. And the parents get more and more anxious. My child has got something, that's why the hospital has admitted. If, as he correctly said, if we have that confidence, okay, deal with these seizures at home, nothing is gonna go wrong. And when to bring to the hospital, if they have that strategy at home to manage this seizure, I think we'll be fine. Most of the hospital can stock at least the rectal diazepam. I know we're having difficulties for buccal midazolam, but emergency medicine probably are underprescribed. That's what I feel. So that can be prescribed at pediatricians.
As I agree, Dr. Vivek, with you, as I said, especially for those who had previous prolonged febrile seizure. If someone had a prolonged febrile seizure, I would definitely give them, apart from education, option of using rescue midazolam, buccal or intranasal.
Dr. Kalpana?
So, Dr. Gorab, I think it's time to wrap up. I think.
Before that,
I wanted to ask Dr. Ubaid before that, the invasive stereo EEG, there's a facility available in UAE.
That's right. As I said, we have, stereo EEG, although it looks very fancy, it is just an EEG that we use in situations wherein the surface EEG has not given us a confidence that we know where the epileptogenic zone is. But before we we can't just be saying, okay, we don't know, we want to insert the electrodes.
No.
It needs
Obviously
sometimes we will
not.
do
It's
2 or 3 admissions for a non-invasive EEG, because that is what we call phase 1 evaluation. All the steps that I followed in the slide, we use that, and then if there is a candidate for stereo EEG, we are able to offer it.
Yeah, so definitely case selection is very important. Your evaluation is important before you go for stereo EEG. As far as video EEG
Yes.
is concerned, is that the norm now?
Yes. So at American Hospital, we established American Center for Epilepsy, wherein we have dedicated beds for epilepsy monitoring, wherein patient comes in for an elective admission, either for overnight or for 24 hours or for 48 hours, depending on how frequent their episodes are. We evaluate them. We continuously monitor them, both EEG and video. Parents have ability to press the button for any event, and then we evaluate it over there. We also have availability of doing it at home, so we can children, especially those who have challenging behaviors, they can come. We can set it up either in the hospital or even at their home, and we can remotely monitor them, both video and EEG. So I think it's an important diagnostic tool from the epileptologist's point of view. I think video EEG monitoring is the most valuable tool apart from evaluating this. Yes. It helps us in guiding further as to which way to head, what investigation to do,
and you spoke about
and to clarify if the particular episodes are epileptic or not.
And you spoke about epilepsy protocol MRI. How is it different from the normal MRI?
Trust me, it is vastly different. I had to fight it with my radiology department to get it done. It takes 3 times the time than a regular MRI because it's got lots of sequences. As I said, some of the like from one end of the brain to the other end of the brain, there are like 350 slices, and you would often do that only after the epilepsy evaluation, because we need to tell them where is the focus, where is the suspected focus, so they can do more thinner slices around that area. So the problem is the MRI machine time. That's the thing. So, and we do some special sequences called inversion recovery and other things, but it depends on the information that we gain from the comprehensive evaluation before we request that MRI.
And the sedation that you use for the process doesn't interfere with your EEG?
Yes, we never do. I never use sedation for EEG.
Okay, and for MRI?
For MRI, we use general anesthesia. Because it can't be done
because you need anesthesia for a long.
The image quality is not good. For anyone less than 7 years old, we do epilepsy protocol MRI. As I said, it takes almost an hour for acquiring all the sequences. It cannot be done under sedation. It has to be done under general anesthesia because it's a very long MRI.
Right. Thank you, Doctor. Okay, Dr. Saurabh, I think we've covered from diagnosis to treatment most of the important aspects. If there are any more questions, I think we will forward them to the panelists.
Yes. Now, before that ending, I would like to announce this, that I think Tawfiq will tell us, Dr. Tawfiq will tell us more than 1,000 viewers, I think we had. I mean, the exact number will come. Now, before ending, I want you, Dr. Shah, you said about West syndrome and some historical aspect I would like to say. Actually, this was Dr. Charles West. He diagnosed his own son. He established a great Armand Street hospital along with Charles Dickens' writer. Second, this phenobarbital they are using, it is interesting to know it was named by original synthesizer after a charming lady called Barbara. Girlfriend was Barbara. Now, some people ask me why this Dr. Shah has used fidget. Actually, the history of fidget, this is a Nordic, North Scandinavian country, old Fiki, it is called Fiki. It means the person who is holding the pen in his hand and going on shaking it. That is why it has come from there. And thank you very much, Dr. Shah, for excellent presentation, discussion. Dr. Vivek for wonderful taking part in the discussion and questions. Dr. Diari, Dr. Kalpana, Dr. Tawfiq, I would like to thank all of you. I would like to thank all viewers, more than 1,000. Now, exact figure will come. Really, if we go like this, I think in India is, I think 1 o'clock midnight. They are following us. Thank you very much. Thank you very much. All of you, inshallah, in the next meeting, we will have more discussion on neurological aspect.
Thank you,
Thank you
everyone.
very much and good night. Thank
Good
you.
night. Good night. Thank you.
Good night. Thank you.
Thank you very much. Thank you.